Welcome to this Step 3 review focused on cardiology case simulations. This video is brought to you by Roadmap to Residency. Today we are not going to reteach cardiology from the ground up. Instead, we are going to show you how the case simulation and vignette question stems are actually built and how to attack the 4 cardiology scenarios you are most likely to meet on test day. Those are chest pain, heart failure, dangerously high blood pressure, and an irregular heart rhythm. Keep your question bank and a trusted review resource open alongside this video, because these patterns lock in fastest when you drill real questions. Let us get started. Here is what we are going to cover. First, you will learn to recognize the 4 cardiology stems that show up again and again, and to lock onto the exact question being asked before you touch the answer choices. Second, we will train the single most important cardiology reflex on this exam, which is separating the stable patient from the true emergency, because where the patient is and how sick they are drives the correct answer. Third, we will walk 4 full case simulations together: chest pain, heart failure, dangerously high blood pressure, and an irregular heart rhythm, and explain exactly why each answer choice is right or wrong. This video assumes you already have baseline knowledge from your review resources. We are here to sharpen how you take the test.
Our first strategy is to read every cardiology vignette like a physician deciding what to do next. Start with the last line of the question. That sentence tells you whether you are being asked for the next best step, the most appropriate test, or the best treatment. And in cardiology, that distinction changes everything. Once you know the question, go back and read the stem with that goal in mind, and you will stop drowning in detail. Then anchor on the setting. Chest pain in a comfortable clinic patient with normal vital signs is a very different question from chest pain in the emergency department with an abnormal tracing and unstable vitals. Train yourself to notice the setting and the vital signs every single time, because they usually point straight at the answer.
Strategy 2 is the reflex that carries every cardiology question on this exam, which is deciding stable versus unstable before you do anything else. First, check the vital signs before you even look at the answer choices. Blood pressure, heart rate, oxygen saturation, and mental status tell you whether you are dealing with a stable patient you can work up in an orderly way or an unstable patient who needs treatment this minute. Second, let that instability pick the answer. When the patient is unstable, the next best step is almost always immediate treatment or stabilization, not one more test. When the patient is stable, the exam rewards an orderly, cost-effective workup. If you match the intensity of your answer to how sick the patient truly is, most of the wrong choices eliminate themselves. Strategy 3 is cost-effectiveness and appropriateness, which this exam weaves into a huge number of cardiology questions. First, start with the cheapest useful test. When the answer choices range from a focused history to a tracing of the heart to advanced imaging, the next best step is usually the simplest test that actually changes what you would do. And in cardiology, that is often the electrical tracing and basic blood work before any scan. Second, match the test to the risk. A low-risk patient with atypical chest pain does not need urgent invasive imaging, and a patient with an active heart attack should never be reassured and sent home. Third, beware the overkill answer. The writers love to offer urgent invasive imaging or an immediate procedure that does far more than this patient needs right now. It feels thorough, but on this exam, doing too much is wrong just as often as doing too little. Let us work through our first case, and this one tests whether you can recognize a true cardiac emergency. A 60-year-old man arrives in the emergency department with crushing chest pain for 1 hour that radiates to the left arm, with sweating and nausea. His blood pressure is 150/90. He looks distressed, and the tracing of his heart shows clear ST segment elevation across the anterior leads. He has already received aspirin. The question asks for the most appropriate next step. Before you choose, notice the setting, the classic story, and above all that abnormal tracing, because together they define an emergency. Read the 4 options carefully and pick your answer, then we will reason through them together on the next slide. Let us break this down. First, spot the pattern. Crushing chest pain with sweating and nausea, together with ST segment elevation on the tracing of the heart, is a heart attack from a blocked artery, and it is the highest urgency pattern in all of cardiology. That abnormal tracing is the single detail that turns this from a leisurely workup into an immediate treatment question. Second, apply the rule. For ST elevation, the next best step is opening the blocked artery as quickly as possible with primary coronary intervention, and nothing outranks getting that artery open. Third, eliminate the wrong answers. An outpatient stress test is actively dangerous during a heart attack, and it is the trap for anyone who skipped past the tracing. A chest scan only wastes precious minutes and does nothing to open the artery. Reassurance and discharge would be fatal. The correct answer is reperfusion with primary coronary intervention. Notice how the abnormal vital signs and the tracing forced an emergency answer. Here is our second case, and it tests acute heart failure. A 70-year-old woman with known weak heart function comes to the emergency department with 3 days of worsening breathlessness, swollen legs, and an inability to lie flat. Her blood pressure is 160/90. Her oxygen saturation is down at 88%. Her lungs have crackles throughout, and she tells you she stopped her water pill last week. The question asks for the most appropriate next step. The whole picture is a patient overloaded with fluid and struggling to breathe. So think about what relieves that right now, and watch for the choices that would make her worse. Pick your answer, and we will reason through every option on the next slide. Let us work through this answer. First, read the overload picture. Breathlessness, an inability to lie flat, swollen legs, crackles throughout the lungs, and an oxygen level down at 88% all point to a body overloaded with fluid, and stopping the water pill last week is the trigger that tipped her over. This is an acute heart failure exacerbation, and she needs 2 things relieved right now: the low oxygen and the excess fluid. Now, why do oxygen and diuresis win? Giving supplemental oxygen along with an intravenous loop diuretic directly treats the low oxygen and pulls off the extra fluid, and the patient usually feels dramatically better. Look at the traps. A large fluid bolus would essentially drown her and is the dangerous distractor for anyone on autopilot. Starting a high-dose beta blocker during active fluid overload can worsen the failure. Discharging her home at this oxygen level is unsafe. The correct answer is oxygen and an intravenous loop diuretic. Let us talk about pacing, because cardiology vignettes are long, and this is where strong test takers lose time. First, recognize the pattern fast. However dense the stem, the cardiology answer almost always turns on just 2 or 3 details: the vital signs, the tracing of the heart, and the setting. If you train yourself to hunt those down first, even a wall of text still takes only about a minute, because your speed comes from knowing what to look for rather than from reading every word faster. Second, flag, move on, and bank time. If a rhythm strip or a dense vignette has stalled you for more than about 90 seconds, commit to your best answer, flag it for review, and move forward, because letting one long cardiology stem swallow the time of 3 other questions is how blocks go unfinished. Bank the seconds you save with quick pattern recognition and come back to the flagged questions at the end. Here is our third case, and it tests dangerously high blood pressure. A 58-year-old man arrives with a blood pressure of 220/130, along with a severe headache, blurred vision, and confusion, and his examination shows swelling of the optic discs at the back of the eyes. He has no chest pain. The question asks for the most appropriate next step. The detail that must jump out at you is that this is not just a high number, it is a high number that is actively damaging an organ, in this case the brain and the eyes. Keep that in mind, and be careful of the choices that either do too little or lower the pressure too fast. Choose your answer, and we will reason through every option next. Let us break down this answer. First, spot the organ damage. A blood pressure of 220/130 with a severe headache, confusion, blurred vision, and swelling of the optic discs is a hypertensive emergency because an organ, here the brain and the eyes, is being harmed at this very moment. It is the organ damage, not the high number by itself, that makes this urgent, and it means the patient needs admission for controlled intravenous blood pressure lowering. Now the key distinction: lower the pressure slowly, not fast. Giving a rapid tablet and discharging ignores active organ damage. Driving the pressure all the way down to normal within an hour can starve the brain of blood flow, and that overcorrection is a classic trap. Waiting a week to recheck is plainly unsafe when an emergency is unfolding. The correct answer is admission for careful, gradual intravenous blood pressure lowering. Our fourth case is an irregular racing heartbeat, and this pattern lives or dies on the stable versus unstable reflex we built earlier. Here is the rule in 2 halves. First, the unstable patient. If someone has an irregular racing heartbeat together with low blood pressure, chest pain, breathlessness, or confusion, they are unstable. And the next best step is an immediate synchronized electrical shock of the heart. Whenever the stem shows those signs of instability, the rhythm question instantly becomes an emergency treatment question. Second, the stable patient. If that same irregular rhythm patient has normal blood pressure and looks comfortable, you have time, so the answer shifts to slowing the heart rate with medication and assessing the patient's stroke risk to decide on blood thinning. So the entire question turns on the vital signs in the stem. Read them first, and they will tell you whether to shock the heart or to take the calmer rate control and clot prevention path. That wraps up our cardiology case simulation strategy for Step 3. Remember the core ideas. Read every vignette like a physician deciding what to do next, and start with the last line. Before you choose, check the vital signs and decide stable versus unstable, because that reflex answers chest pain, heart failure, dangerously high blood pressure, and an irregular heartbeat alike. Give reperfusion for the heart attack with ST elevation. Give oxygen and a diuretic for the overloaded heart failure patient. Admit for careful, gradual lowering in the hypertensive emergency, and shock the unstable rhythm while rate controlling the stable one. To master the content behind these patterns, work through a comprehensive board review book and a trusted case simulation resource, and drill questions under timed conditions while reading every explanation. Visit roadmaptoresidency.com for expert tutors and residency advisors who can build you a personalized plan. If this video helped you, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.